emerging problem in total hip arthroplasty, which is immunosuppression and superbugs. Talk by Dr. Kujan Nagaratnam.
I'll take 10 minutes. Then you can all go.
Painful?
Yes. Okay. One of our major weapons are antibiotics. And when somebody rings me these days, 48 hours post-op, or they got fever, it scares the hell out of me. It's been happening in the last, I have nightmares. I'm not worried about having heart failure, myocardial infarction, something happening. I'm worried because we are running out of our major weapon we have. And I was here in India a month ago, and I opened the paper, Hindu, and it's on the front page. And it's a worry all over the world, right? WHO, same thing, you're running out of antibiotics, and it is a problem. If you look at how long the antibiotic resistance lasts, when initially when the sulfonamides were done, you had a long period, 20, 30 years. And the last ones, ciproflox, resistance lasted about 5 years. And all the big guns we have in the recent times all have only 2-3 years and started getting resistance. And it's a scary thing on a personal basis, and it's also a scary thing to see that we don't have anything to combat things in the very future. So, and the other problem is you're running out of antibiotics that have been developed. You can see in 2008 to 12, we had only 2 or 3 antibiotics got approved by the FDA. And those ones, the resistance sort of coming within 2 years, right? As Jim said, we do take advice from the infectious diseases specialist when we get into consult them. And their approach is, although they want to have sort of antibiotics to be given properly and appropriately, their advice is sometimes variable, which frustrates us. And the numerous studies have found that a large percentage of antibacterial prescribed are inappropriate, and that's the reason, because of no bacterial infection, no ineffective antibiotics or inappropriate antibiotics. That said, if you get pieces of metal into you, like hips, these days, it's amazing the amount of metal you have. You've got a pacemaker in with a pacing wire. You've got screws in your back, hundreds of them. You've got brain stimulators for Parkinson's. You've got prosthetic aortic valves. You've got valves everywhere. You've got stents. You've got hundreds of pieces of metal. The older you are, the more the pieces of metal you have. And when you have bacteremia, something's going to get stuck in those places. And it's scary. And not to treat with antibiotics when they have febrile, ESRs up, is very scary not to use it, even though it's inappropriate. You go for the big guns, obviously. You're trying to get the big guns. Unfortunately, if you look, this is a European EU surveillance which they control, and you can see in the southern European countries, for population, 30% per 1,000 are given antibiotics appropriately. So it is inappropriate use is quite widespread from this European data. So around the world, they got antimicrobial stewardship. As you say, to reduce inappropriate antimicrobial use, improve patient outcomes, reduce adverse effects and toxicity, reduce costs, etc., because you run out of armaments. And unfortunately, although this is all there, even them dealing with them all the time, and they're experts at what they give one patient one advice and the next patient some other advice. And they also found their basis of selection of giving advice is, I think, is not scientific, because they are running out of any armaments to give you. They have guidelines. Again, you're trying to put the guidelines into individual patients, and it doesn't fit. they restrict us. I'm not sure how restriction is. So we sometimes have to, the last on the right, the antibiotics on the right, we also have to always ring and get approval. They audit on antimicrobial use. And again, they have trying to get surveillance to see what resistance they have in the area we practice in the, the locality or the hospitals, etc. The resistance, the reason things are getting more dangerous these days or more difficult is that the bacteria, every time we use an antibiotic, some bacteria gets left behind, and those spread, those reproduce very fast and cause resistance. And they got three major mechanisms of resistance. That's enzymatic degradation, antibacterial use, alteration of proteins, and they'll take, within days they come on, and changes in membrane permeability. And most of the things these days are plasmid mediated, and they are in antibiotics in organisms that come from the bowel. I call it from the skin. MRSA or stuff come from the skin. Now it's all bum. I call it they come from the bum. And they are E. coli, Klebsiella, Enterococcus. So you can see they are the most resistant. And using cephalosporins, and which we use for antibiotic cover, and penicillins, within 2-3 days they become resistant, unfortunately. Their beta-lactamase resistant. I'll give you a list of the mechanisms. I won't waste time. So as you know, ESBL is the one we talked about, and they prevent certain antibiotics from able to kill the bacteria, right? And it's all over here. All over here, it's spreading towards the West Australia. It's becoming quite common. And the major cause of use is, I think, used because of penicillins and cephalosporins, used for usually urinary tract infections and skin infections. Okay. And the other thing I told you about, we're trying to build a better human with pizometalin, and they are all at high risk of getting infected. So any one of them is going to get infected when you have, even having a short period of bacteremia. And bacteremia in humans are pretty common. You know, you get a skin cut, you do have bacteremia, but your resistance, your protection mechanism just cuts it off. Unfortunately, the protection mechanism, when you don't have antibiotics, is a problem. This is an issue. When you have antibiotics, you're fine. This is an issue when you don't have antibiotics to cover you. And whenever you intervene someone, and especially they are older, their resistance goes down. And we got away with it by covering them with antibiotics. And now if you don't have that armory, we are in trouble. What happens basically is that although the white cell count number is okay and the platelet number is okay, sometimes the platelets go up, the white cell goes up, that's a stress reaction, right? The subpopulations of leukocytes do not protect you. So they are immunosuppressed from the number that is able to work and protect you from infection, and suppressed also their function is abnormal. And this is scary, and I always worry in elderly people whether we are covered adequately. Sometimes we drag the antibiotics a bit more longer, especially the wound's not closed up or oozing a bit, but my infection diseases colleagues are not happy, right? What do you do with it? Reduce the stress. Minimally invasive surgery, the time of surgery, and then reducing something like pain control. Even pain causes suppression of your protection mechanism. Anti-inflammatory agents, it's fine, except I'm concerned about the effects in elderly and people with ischemic heart disease, etc. So you get into trouble with using some of them, but we may have to depend on them and change the modality of surgery and the time, right? Solutions, discovering new antibiotics. You've got a problem there, we're running out there. Maintaining gut flora, as I say, it's from the gut that most of the nasty ones are coming up now. In fact, the people with MRSA survive a bit longer than the people with E. coli in any sort of piece of metal. precise delivery system so that you don't cause too much resistance. I think the major issue from my point of view is if you can get your resistance profile straight away, some mechanism of getting it straight away within a few hours, that'll be great. And I think we are coming to a point where we're going to have barrier nurse everyone. E. coli, ESBL, it's on your piece of paper you bring to the patient, it's on a nurse's hands, it goes with soap and water, it's on everywhere. And just imagine barrier nursing everyone in the whole day and stay in hospital, nightmare, right? Then there's new technology, I'll put something in, you can have nanotechnology, metal that kills people, you know, the silver nitrate and all the starter stuffs. There are nano-enabled antibiotics, mainly to have delivery systems, and then other approaches, silver, putting into other delivery system using nanotechnology. This is in place of antibiotics, but it's early stages, and hopefully get there. So the future hell, it's used to, all of you ought to decide, or is it heaven? In fact, every single patient I see, I now started from last year to I wear gloves. It's sometimes inappropriate, it looks odd, but I wear, examine everybody, I wear gloves. Because it's just protecting the patient and from room to room, even though you wash and clean and put alcohol, every single patient. It's unfortunate, but it's heading there. You don't know. Thank you on that note.